Australia, the childhood demand for sex reassignment treatment surges to a record high. Childhood sex reassignment treatment.
That's because they're upside down on their heads.
It says the number of children seeking transgender treatment in Victoria will surge to 300 this year alone, just in Victoria, according to new public hospital figures. In 2007, in 4 years, they only had 3 patients. Well, guess what? With her, now with her wonderful thing, because she helped write the recommendations for all these kids, now by the end of this year, they have 1,000 children that are going to be seen.
That are going to change their sexual identity.
Well, that are considering it. So therefore the programming is working. It went from 3 to 1,000. So great job, not Professor Telfer. Now she did say that apparently wait times for appointments are up to 14 months as hospitals struggle to cope with these influx of patients. So instead of seeing a regular doctor, they now have nurse consultants and junior doctors, whatever that means. I guess they're in training. So the wait time is down to 4 months to do the initial assessment.
Sure, they'll give them professional advice.
Now listen to this. From there, once they see the nurse consultant and the junior doctors, then they get pediatric and psychological approval to begin puberty blockers and hormone therapy.
How old are these children?
Children. So
how old?
18 and under. 18 and under. Now right now, the public hospital does not offer gender reassignment surgery. They call this bottom surgery. Bottom surgery is anything below the waist is not recommended for children and teenagers because of its effect on sexual and reproductive function, according to this professor. I'm saying that loosely. Now I'm going to tell you, puberty hormone and puberty hormone blockers and puberty blockers.
That's not right.
That doesn't affect sexual and reproductive function. That doesn't mess them up, but the surgery does. Right.
I'd like to see their parents.
But she said top surgery, that's above the waist. She said that's okay. But she said it's very distressing for them not to be able to have top surgery. These are children, right? She said when you still have prominent breasts, it's very distressing and actually leads to quite a lot of discrimination, stigma, and bullying at school. So she said the evidence that we have from a medical perspective is top surgery can be really helpful and therapeutic.
I heard that.
So apparently a family court used to be the only ones who could say children and teenagers could get this hormone therapy. They don't have to do that anymore. And hormones are covered by the, get this, pharmaceutical benefits scheme.
That's benefits?
Scheme.
That word doesn't belong
Scheme,
there.
but puberty blockers are not. So now this professor are drawing up new guidelines for treating transgender children and teens and published it in the Medical Journal of Australia.
Yeah, Australia is turning into be a really super country.
She said that access to treatment was still lacking in many parts of Australia, and it says the hidden price tag of being transgender is $100,000.
That's the whole bottom line
Right.
for why they
And I saw that. Yeah, well, it's part of the bottom
They
line.
don't give a shit about the children. They care about the $100,000.
Well, and they care about the programming that they're installing, and they're making them pay for their own programming. And people.
I'm a pediatric endocrinologist who practices in private practice in Atlanta. I'm on the clinical faculty of 2 medical school pediatric departments in Atlanta. Love teaching, love clinical practice. I've been an endocrinologist for 38 years. I've been practicing pediatrics for 42 years. Had a 20-year career in the Navy before I retired from the Navy as a pediatrician and pediatric endocrinologist and moved to Atlanta under sort of unusual circumstances that turned out to be fantastic for me and for my family as we raised our kids to adulthood in that lovely part of the South. So my experience in transgender medicine goes all the way back to my fellowship days at Johns Hopkins where I trained. And I'll start discussing the issue looking backwards at the history of transgender medicine as it has unfolded in the United States. I refer to the 3 musketeers, Alfred Kinsey. He was not a physician. He had a degree of science in entomology, which is the study of insects. He started, because of his interest in sex, the Kinsey Institute in 1947. John Money, who was a psychologist, graduated from Harvard, and joined the faculty at Johns Hopkins as a clinical psychologist in 1951. I read a little bit of his biographical statement about his relationship with Johns Hopkins as a young person. And he was not a physician, did not go to medical school, but he did say he spent Saturdays in the pediatric endocrine clinic for a year. And as far as he was concerned, he was better trained than most pediatric endocrinologists. So he visioned himself as a medical physician and an expert in the field, even though he had no formal training. And then Harry Benjamin, who I originally had assumed was a psychologist or a psychiatrist. Turns out he was a general medicine physician who also had a whole lot of interest in things related to sex. And he had a private practice that failed a number of times. It finally took hold in New York City. And he would go to San Francisco in the summer and practice there. So this is a picture. If you look closely, there's a person on your far right. That was me as a fellow. I had hair and it was dark back in those days. And in the center you can see another person who has a circled head, and that is the infamous Dr. John Money. Looks like he has a horn coming up out behind his head there, which is sort of appropriate. He introduced the term gender as a psychological construct. Previous to the 1950s and 60s, the concept of gender was actually developed for languages. So you had masculine nouns and you had feminine nouns. So it was le chat and das Hund for dog and cat in French and German, and then feminine, la chaise and die Kirche, which was for the chair and the church in French and German respectively. So John Money decided lots of things. He had lots of ideas in his head, and he thought that gender was going to be used as a term to show the internal sexed self as either male or female. So it was taken out of the linguistic world in the 1950s and 60s and placed as a term in the field of identifying human beings and their gender orientation. So he started what he called the Psychohormonal group at Johns Hopkins. He had trained in Boston and was intrigued by the opportunity to study patients that had issues with sexual differentiation, so-called hermaphrodites or pseudohermaphrodites. And at Johns Hopkins, at that time, it was sort of the place where steroid biochemistry was being unfolded, and the concept of how cortisol is made and how the offshoots of the steroid hormones are developed in the adrenal gland, and what mistakes in nature happened to cause what we now call disorders of sexual differentiation. So most of the patients in the United States, and actually from around the world, were referred to Baltimore to be evaluated for what caused their disorder of sexual differentiation. And this is a very tiny fraction of patients. We're not talking about hundreds and thousands. We're talking about initially 10 or 12 patients that were studied, just to look at why the accident of nature happened and what the consequences were on physical exam. So John Money thought, well, there is an opportunity for me, as an interested psychologist, to look at the concept of where one perceives their gender and if social circumstances can change a person's gender successfully. So that he decided he was drawn to Johns Hopkins as a result. So he joined the faculty and established protocols to evaluate these kids, both pre-treatment and post-treatment, and to see what happened in patients with abnormal anatomy or early or delayed puberty. So he developed, at the same time, an adult transsexual program, and it was not called transgender then, it was called transsexual. These were adult patients who believed they were born into the wrong body, and they were recruited through newspapers locally and regionally through the grapevine. There was no internet back then. And they had cross-dressed these individuals in their intended new gender for 2 years. That was the social transition phase first. And then they administered cross-sex hormones subsequently if they had been able to succeed in their new gender role in the workplace and at home socially. They did not have puberty blockers because these were all adults who had already been through puberty. The surgical procedures then to alter their genitalia were developed, and they actually, in the process of learning on big people, the surgeons translated that down to surgeries that could be done on infants and toddlers who had abnormal genitalia that needed correction. So there was a spin-off from the adult program that worked its way down through pediatric surgeons and subspecialists. So this is one of the patients that changed from male to female. We, as pediatric endocrine fellows, unfortunately, were the ones that had to follow these patients into their adulthood, even though they weren't pediatric patients. So Don Trella, as you might have guessed, had a day job, and it wasn't a particularly socially acceptable one. Money scientific protocols. He had an idea, and he says, he would actually call up and say, I've been thinking, I have a really neat idea. And then he would say, let's do something to the patient and see how it comes out. Now this sounds bizarre in an era where we are so intent on following good science, but that's as far as his science went. So John Money decided he was one of the leaders in medical castration of sex criminals. The only drug that we had at the time that would work was medroxyprogesterone, long-acting, or so-called Depo-Medrol, or rather Depo-Provera. And that was given to incarcerated individuals in prisons that had been sex offenders to see whether or not they could control their sexual urges. He had directed interviews with our pediatric patients who had disorders of sexual differentiation or who had precocious puberty for either reasons that couldn't be discovered or who had tumors that produced these kinds of hormones. During these interviews, the boys were taught how to masturbate. We actually had to read through these reports, and the interviews were very interesting because the first time a 6-year-old boy with precocious puberty came in, the interviewers would say, how often do you masturbate? And the little 6-year-old would sort of scratch his head and say, what's that? And so they would show him with a pencil, this is how you masturbate. Next interview, he came in, the boy was masturbating 6 times a day. So it was a kind of a lead-on interview. It was actually rather perverted, but this is the kind of stuff that John Money's program produced at Johns Hopkins, a very venerable institution. Then there was the tragic case of the newborn boy twin who had an amputated penis. During the process of trying to do a circumcision, the unwitting surgeon took a Bovie knife, which is an electrocautery device, to touch an area that was bleeding and essentially burnt the child's penis off to the base. And so that boy in the newborn nursery had a brother, twin brother, and that boy was raised at the advice of John Money as a girl. Surgically, the gonads were removed. The stump of what was left of the phallus was sort of fashioned into a clitoris. There was a vaginal opening created using the surgical techniques, and this child went home from the hospital as a girl. Then there's a case that I took care of a child named David who came down from Buffalo, New York to our clinic because he had what was called a micropenis. A very, very tiny phallic structure and no palpable testicles in the scrotum. We evaluated this child at age 6 weeks, and we decided we would put this child through a protocol, which it was to use a hormone that would stimulate the testicles to produce testosterone. In doing so, we would find out if the baby did have testicles, and after that, would find out if the testicles produced testosterone, would the baby's penis grow and would the tissue respond. All those things were very important for us to know in terms of figuring out what this child should be raised, either a boy or a girl. So unbeknownst to us, John Money we thought he was out of the country, but he actually had come back early from a tour somewhere, and he interviewed this family without our knowing it before the family left home and told the mother and the grandmother that what we were doing with hormones was absolute nonsense. There was no possible way that the child was going to be able to be raised as a boy because nothing we could do would fix that. So he sent the baby home with the mother and the grandmother, telling them to change the name, and they chose Tabitha, and to cross-dress the baby as a girl. 6 weeks later, the baby came back for us to evaluate the baby, and the baby, Tabitha, had a normal-sized penis and testicles down in the scrotum, indicating clearly that it was just a boy with a pituitary deficiency and not somebody that needed to have their sex changed. It was that particular case that sort of ended the relationship of John Money with the pediatric endocrine division at Johns Hopkins, and later they closed his program down. So the suicide, that boy with the ablated penis who was raised as a female, what this showed was this is a boy who was in utero, had all the XY chromosome information that said every cell of his body is male. He had the hormones that bathed his brain because there was no problem of hormone deficiency. His testosterone programmed his system from the beginning. He was changed into a girl surgically as a costume. And he knew throughout his young childhood that something was not right, and when his parents finally fessed up and told him what the story was, he insisted that he be changed as a young teenager back to a boy, and he assumed that role, and then he committed suicide. That made headlines across the country, and that was sort of the last nail in the coffin for John Money and his crazy ideas. So the interesting thing about the disorders of sexual differentiation, and I as a fellow had learned that if you had a baby that looked completely feminized or non-virilized, there was no possible way that that child could be reared as a male. It would have to be reared as a female. The study of long-term follow-up of these patients, there were 16 of them. 2 of them ended up remaining as they were natally, as males. The parents did not want any surgery or any correction. Of the 14 that did, 8 ended up growing back up and reclaiming their natal sex as a male. So even with our well-intentioned ideas based on the concept that gender is your natal sex is not innate, that there's gender that can be changed by society, it turned out that was not the case. So the poor outcome in adults, the adults that went through the transsexual program at Johns Hopkins ended up as a group of about 50 patients. They were studied in adulthood, and they seemed a bit content with their new selves, except that their female appearances were pretty much caricatures of females. They were almost like Disney characters instead of actual women. They wore an incredible amount of makeup. They had no incentive to think about any parenting skills, and they ended up keeping all of their neuroses they had beforehand. They were not improved at all. And so on that basis, Paul McHugh, who had joined the faculty at Johns Hopkins a long time before and who became the psychiatrist-in-chief in 1974, closed down all of the efforts at Hopkins that had been started by John Money. So if we look at transgender clinical services over the decades before 2006, in the Netherlands, they had adults that persisted with gender identity, and they were treated with medicine to transform their physical appearance to the opposite sex, and they were also treated surgically. In Toronto, Dr. Kenneth Zucker, who was a psychologist, had a large series of patients who he counseled through their gender identity crisis and got them to be essentially returned to their natal sex in 98% of the cases in boys and upwards of 80+% in females. It is that classic work, that long, hard 35 to 40 year experience of his patients in Toronto that gives us the strong statistics about the existence of the transgender identity. Then he had experience with greater than 500 patients, 560 patients to be exact. Then in Boston, Dr. Norman Spack, who had taken a trip over to the Netherlands, he was sort of fascinated with the transgender idea. And he went to the big clinics in the Netherlands where this had been in practice for a number of years. And he thought this would be a great idea to start in the United States. And so he came back to Boston and started what was the first East Coast Transgender Center in 2006. So in 2006, there were basically 2 places in the country where if you had transgender issues as a patient, you could be referred to the experts, since Baltimore was gone. And that was in Boston and then eventually in Los Angeles. Now, there's a group called the Harry Benjamin Society, named after that infamous character who was one of the 3 musketeers sexologists. Its membership requirements are very, very strict. You have to be interested in transgenderism. That's it. You do not have to be trained in medicine. You do not have to be, all you have to do is say, I'm really a proponent of transgenderism. And you sign up and you get in as a membership. That's a professional society, supposedly, and there is no requirements for specific education or professional background. So the Harry Benjamin Society sort of disappears, and in its place is the World Professional Association of Transgender Health, or WPATH as it's known. WPATH is not happy with the existing medical literature. The studies we had from Kenneth Zucker with his greater than 500 patients showed that desistance of transgenderism was prevalent if you let these kids go through puberty naturally. That's a large number of patients, 560 to be studied over all those years. And then the study from Sweden, which is a country which has been very permissive and very accepting socially of transgender patients into adulthood, published a study of 330 plus patients, or 324 patients, of transgendered adults who persisted into adulthood and had been treated either with medication or medication and surgery. And their data showed that there was a 20-fold increase in suicide in those patients compared to the non-transgender community. That blows it out of the water. This is not something you can sweep under the rug as a poor study, poorly conceived. It was every single patient, like it or not, was included in the study. And again, the same thing with Dr. Zucker's study. He did not exclude a single one of his patients from the database. So the WPATH, in order to get around this kind of powerful research and experience, creates its own bibliography. The quality of the studies that they research are poor for a number of reasons. They're very, very small numbers, studies of as little as 5 patients. The recruitment is based on people saying, we're going to publish a study about how you're doing as a transgender. Please contact us if you're interested. Okay, now, in a society where if you are not happy with your transgender self, you are going to be ostracized and receive death threats, you're not probably going to raise your hand and come to that study and be recruited. You're going to sit quietly and say absolutely nothing about how miserable you are. So it's a biased population. I want all happy people to raise their hands. Okay, all happy people, raise your hands. Are you happy? Gosh, 100% correlation. Okay, so it's like the silliest thing in the world to call that good science. We don't do that with other areas. There are no control groups in their studies. Very, very few of them, if any, have anything that could be considered a study where they had a treated arm and an untreated arm in the study and compared the outcomes. So, and there are many anecdotal case reports. If you look through the WPATH bibliography, it's woman, transfers to male, has happy life. Okay, and it's basically the woman writing her happy self, or the guy writing his happy self, saying how wonderful things came out. So their bibliography is full of these kind of anecdotal things. They also use recycling of the same information. Somebody will write an article in a journal that is perhaps based on some kind of competent research or incompetent research, and then that will be quoted, and then that will be rewritten into an article in what we call a throwaway journal, which is a journal that basically does articles, sort of summary articles for people who are interested in the field but are not specializing in that field, and they want to know a little bit about it. And in pediatrics, Pediatric News is one of those, or Pediatric Annals, or Contemporary Pediatrics. These are not journals that have peer review with the kind of restrictions for the scientific journals. They're basically sort of like a throwaway rag at the grocery store, where you've got a summary real quickly where you can go through bullet points and maybe learn something and file it away if you're interested in that. So they'll recycle it through those, and all of a sudden there'll be 5 different articles and 5 different throwaways, all about the same subject, all written by the same person, and they count those as 5 independent references. So this is how the WPATH, the bibliography, comes about. Citations that are marginally related are used. They'll in the list, if you pay attention, they'll say something about chick oviduct bioassay in the castrated rat. And you think, well, what did that have to do with anything? Well, it looks scientific. It's got a Journal of Hormone Research. That's a really respectable journal. Gosh, look at that reference. That's a really powerful one, when it has very little to do with anything in the actual subject matter. So you can make yourself a 270-item bibliography that looks really powerful. And if you look at a lot of what's done, it's a cut and paste. You can tell that the same articles are referenced when they do write their articles. And so it's a very poor science. They also have created, the WPATH has created its own Journal of Transgender Health. Now, this is supposed to be a peer-reviewed journal, okay? If you imagine that everyone who reviews it is a member of WPATH or believes in that, Can you imagine the quality of the articles that you're going to find? Will anything in terms of contradiction to a transgender affirming concept be approved or published? Absolutely not. So but they have a medical society, so-called, and their own journal, and that gives them credibility. These things make a huge difference in the medical community. For my colleagues who are not in my subspecialty, they are totally dependent on this kind of appearance, thinking, wow, there's an international group that has its own peer-reviewed journal, and they say transgender issues need to be affirmed, and we need to do hormone treatment, and we need to do surgical treatment, and the sooner the better. This gives steam to the engine. If you wonder why we've gone from 0 to 60, it's because this kind of stuff is sweeping over the medical community, and the vast majority of my pediatric colleagues think it's absolutely total valid science. They have no idea what's behind the curtain. The other interesting thing is that their bibliography at WPATH now completely is devoid of any reference to Dr. Kenneth Zucker, who was the pioneer in gender identity disorder. His name has been expunged as if he's never existed. So they're on the rampage. They have standards of care that they developed for transgender health. They lobby the American Psychological Association to change gender identity disorder into gender dysphoria. The reason that they even kept it in as some kind of disorder was because they realized the poor transgender patients were not going to be able to get any health care paid for if they didn't have a pathologic diagnosis. So they changed the diagnosis from a disorder, a delusional state, to the pain and agony and suffering caused by society for these poor, otherwise normal transgender variant patients. So it legitimizes transgender as a normal variant. It blames society for all of the agony that these patients, and it facilitates insurance coverage for these patients for the treatment of their dysphoria. And as I said, they removed all references to Dr. Zucker and they convinced the Canadian government to actually shut down Dr. Zucker's clinic after all of his 35 plus years and almost 600 patients that he treated successfully. They pulled the plug and let him go. He no longer has a clinic to go to in Canada, in Toronto, where he was. That's the power of this organization. Meanwhile, back here in the United States, Dr. Spack coalesced a group of individuals from around the world, including the clinics in the Netherlands and in Sweden and in the United States. And they put together a set of guidelines. The committee excludes anybody with a contrary opinion. So Dr. Zucker, who is the pioneer, essentially, in this country and this continent, with transgender medicine, was not included to discuss or create the guidelines that the Endocrine Society in the United States, professional organization, was going to adopt. He was left out. Dr. Paul McHugh, who had written extensively from Johns Hopkins, and who previously had been what was called a preeminent, world-renowned clinician, he was left out as well. So in 2009, they put together the guidelines. They did send out a little notice saying, if you're interested in reviewing them and have any comments, please let us know. And at that particular time, I wasn't paying attention. I was a member of the Endocrine Society, but I didn't bother to turn in any comments. I just kind of went by the by. And lo and behold, this comes out in the Endocrine Throwaway Journal. It is the transsexual treatment guidelines, and they outlined those in this particular journal, but it was published in the Journal of Clinical Endocrinology and Metabolism. So the guidelines in a nutshell are, do a psychological assessment. It doesn't tell you how deep. Just say, hey, are you troubled? Check mark, okay? That's all we do. We want to affirm and transition any child who states they are born into the wrong body. We want to block puberty as it begins. At age 16, we want to consider putting them on cross-sex hormones. At age 18, if the patient desires, they can sign on with informed consent for corrective surgery, so-called corrective surgery. Of the 22 guidelines, only 3 meet any degree of scientific validity, according to a standard scale used to create these guidelines. It's used sort of internationally. Of those 3, those were all about concerns about the puberty-blocking hormones and the cross-sex hormones and what would happen to these patients medically that could be adverse. Okay? The remainder of them were based on very little science or absolutely no science whatsoever, and yet the guidelines were published. So the revised guidelines have just been put out by the Endocrine Society. They felt they needed to be updated because of the sudden push in transgender health issues. They added additional concerns about the fact that these patients might have issues with fertility that they should be told about. Now, you're talking to a 12-year-old child about their infertility, lifelong infertility, and cancer risk from cross-sex hormones. And you expect that child to grasp that and understand that and assent to going on the hormones, or have the parents take the responsibility for that. Are you kidding? Are you absolutely kidding? There is no other area in medicine except for chemotherapies for death-causing cancers where that would even be considered as an option. And we're not talking about death-causing cancers here. They suggested earlier cross-sex hormone therapy than waiting till 16, suggested earlier top surgery, that is to say mastectomies in girls, should be done before age of consent. And once again, they lacked reasonable scientific evidence in all but 4 recommendations. They removed all references in these guidelines to Zucker, whereas before they'd had them in there. These are the articles you heard about, the New Atlantis article that Paul McHugh and his colleague, Dr. Mayer, put together. This was a beautifully written, extensively referenced article that had to be published in the New Atlantis magazine, primarily because no other reputable journal would print it because it wasn't politically correct. On the right side, you see the article written by Dr. Kenneth Zucker before his clinic was shuttered, showing the absolutely essential guidelines for treatment of transgendered persons. Not to be left out in terms of guidelines is the Pediatric Endocrine Society, which is a separate organization, decided they wanted to go through and create their own guidelines. For the 2017 guidelines and for these guidelines, I made sure I gave them input. Not a shred of what I said was ever answered or respected in terms of how the guidelines came out. Not that I'm an important person, but they did ask for input. I gave it, and it was as if I never existed. The guidelines are emphatically restating the Endocrine Society guidelines and suggest that all the treatment should be covered by insurance, and that was the most important thing. Now, you hear over and over again, the American College of Pediatricians is a tiny, racist, bigoted, homophobic group from the South. They're all religious zealots, okay? And they are on the hate list of the Southern Poverty Law Center, proud to say, okay? And that makes us feel really good because there's a lot of good company on that list of very decent human beings. But the American Academy of Pediatrics, whose membership is now upwards of 65,000 members of pediatricians and pediatric healthcare providers otherwise, endorses affirmation of transgender and treatment as guidelines of Endocrine Society say. How in the world can 66,000 pediatricians fall behind something that is so absolutely out of control? Why did the American Psychological Association take out gender identity and make it gender dysphoria? Don't these thousands and thousands and thousands of professional individuals understand that there should be some kind of balance, and there should be a little give and take, and perhaps two opinions stated, or at least admit that there's another opinion that should be considered? How it happens is that the general membership is allowed to have special interest groups, and the special interest groups are a tiny fraction of the membership, and they have a bee in their bonnet. They have a cause that they want to go for. Then that special interest group interacts with the executive committee that governs all of the decisions of policies made for the huge membership. In the American Academy of Pediatrics, that executive committee is 15 people. Membership, 66,000. So those 15 people listen to the special interest group, and all of a sudden, it's adopted by the entire society, as if 66,000 people agree. And that's published. The American Academy of Pediatrics, the American Psychological Association, the American Association of Family Practitioners, the Endocrine Society all agree, and they're professional societies, and by God, the medical world totally supports this, and you fanatic, crazy Southern religious bigots are a small splinter group, and we shouldn't listen to you. We get that argument all the time. So, as this is like a domino, the APA, American Psychological Association, publishes something, the American Academy of Pediatrics jumps on board, and then the Endocrine Society jumps on board, and et cetera, et cetera, et cetera. Suddenly, the medical professionals are all in favor of Obamacare. The medical professions are all in favor of transgender transitioning. And in truth, the physicians who work their bones to death every single day and take care of patients where the rubber hits the road have no idea what's going on at the level down where the rubber hits the road. So it was alluded to by David Pickup this morning that why in the world is this transgender thing being pushed by the LGB community? When did they add T, and why did they do that? Well, as he pointed out, if you get transgenderism as born that way and a civil rights in terms of being transgender are protected, then male and female go away, and the whole issue of acceptance of same-sex attraction all of a sudden is moot. It makes no difference if there is no sex one way or the other. So what does the T stand for? It's interesting historically. Originally it was transsexual, then it became transgender. Maybe you can throw transvestite in there as well, as if that is, and it's been blended together by LGBT. They're almost as if everybody that's in the trans community is all the same, which of course is absolutely hogwash and nonsense. Transvestite can be heterosexual males who just absolutely love getting dressed up and putting on nail polish and high heel boots and kinky boots, okay? Or they can be like drag queens, which there's a profession that are not necessarily, they can be homosexual, but many times they are not. The famous one being RuPaul, who says, you can call me anything you want to, I know who I am, okay? And he refers to himself as he all the time. But he is brought into the trans group as if he is actually transgender, when the case is absolutely untrue. The advantage of inclusions in this alphabet soup of LGBT are anchoring transgenders as civil rights, attempting to legitimize born that way, and the wider audience on the internet, which is a huge recruitment tool. The U.S. landscape in 1970, transsexual clinic at Hopkins was established, and in 1984 it was closed. In 2006, Norm Spack opened up his Boston clinic. 2009, Endocrine Society Guidelines were published, and since then we're upwards of 50 transgender clinics nationwide. So originally it's like mushrooms sprouting. The map that had just Boston on it, you see all these mushrooms growing here. There are clinics all over the place, all with experts at the helm, so-called, none of whom have ever been really trained in transgender medicine. The battle to return to science is important. Only gender-affirming experts are invited to speak at academic meetings so that the alternative opinion cannot be heard. I attempted to do a balanced presentation in a meeting in Houston that was Austin, that was held last year for the Endocrine Society, the American Association of Clinical Endocrinology, AACE. And we wanted to have a balanced presentation. What was presented was just the transgender-affirming side, and no one else was invited. The publication after that meeting was describing how forward-thinking the organization was because they had embraced this new trend that was new science and needed to be paid attention to. No mention of counter ideas. The counseling to return to natal sex identity is outlawed in some states. You cannot do that. Your license will be taken away and you could be jailed. LGBT activists seek to destroy the opposition through academic influence. Dr. Mark Regneris, who wrote the paper on issues with kids raised in same-sex families, was removed from his faculty position temporarily. The university ended up having to reinstate him. But his journal article was pulled temporarily, and then when it was reviewed and found to be valid, it was reinstated as an article that did not need to be rescinded. There are many people in academic medicine who keep their mouths shut because their jobs depend on not opening their mouth. If they feel strongly about transgender issues and do not want to affirm patients with therapy, they just lay quiet for fear that if they're not tenured, they're going to be fired. So the major medical journals refuse to publish anything. The ones that we all, New England Journal of Medicine, Journal of American Medical Association, the Journal Pediatrics, JCE&M in the endocrine world will not publish anything that is counter to the gender-affirming concept. So that's why Dr. McHugh had to publish in the Atlantis Journal, because it was a beautifully written article that was polished and would have done beautifully in terms of review. It just wasn't politically correct. So that they forced them to the margin. And then they're doing research providing benefits through affirmation through using a different kind of standard for clinical research. There are ethical guidelines for clinical research that you have to agree to before you do a clinical study. First of all, there must be informed consent. Every aspect of what you're doing as a proposed treatment must be explained, the good, the bad, and the ugly, okay? Not so in gender identity research stuff. Clear assessment of benefits versus harm. The harm, so-called, in not affirming is that the patient has a high risk of suicide. The problem is the high risk of suicide exists anyway. It's not made any worse. Absence of bias, presented as you need to have a balanced approach where you do review those indications that are counter to your proposal, bring them up in your proposal and deal with them and show that your hypothesis might disprove them, but they will be included as a concept. None of that is being done in the transgender research that's currently going on. Independence of safety by an institutional review board with stopping criteria at the very first sign of any adverse effect that affects the patient. So here we have cases already of adults whose lives have been totally tragically ruined, committing suicide or standing up finally and opening up and writing books about how horrible their lives have been in this new transition state. That would be a stopping criteria for the study before it ever got started, but all of that is completely ignored. There's currently funded an NIH study with 4 centers in the United States. They're recruiting kids who are 5 years of age and older, and they are going to affirm these children in all ways, and at the end of 5 years, they're going to find out if they're happy or not. The problem is there's no control group. They didn't choose 40 kids or 80 kids and divide them into 2 groups randomly and say, we're going to affirm you, and then we're going to use the other non-affirming criteria and psychotherapy and see what happens at the end of 5 years in terms of levels of happiness. There is no control group. That would not pass muster in any scientific venture anywhere else. And the evaluation of how successful you are is by asking the parents and the researchers how they have assessed happiness. Again, no independent evaluation of that at all. It's totally biased. It's going to essentially stop puberty, and we're going to have a group of kids moving forward that are treated by something that is an experiment for which they already are going to get the answer they know they wanted. So the details of this study, you cannot find them on the NIH website. It's totally non-existent. You just have to know the study exists by reading about the claims that the study is starting and where they recruited patients from. So there's fallout in the local communities. School boards are railroading through regulations without public hearings. It's happened here in Texas. It's happening in Decatur, Georgia at this point in the Atlanta area. Large corporations are threatening to pull out of municipalities because of thoughts of if you don't accept transgender rights, we're not going to do business with you and your community will fail. And then gender centers of excellence are actively treating patients from age 3 and up with affirming therapies, cross-sex hormones after puberty blockers, in advance of the data showing that it is at all safe or effective. It's already happening. So what can we do to turn back the tide against it? We can always begin with a statement that truly shows that we are compassionate about these children. We do not hate transgender patients. We do not treat them poorly when they come to our offices. We are compassionate. We go to the root of the problem. We find the therapist, such as David, who will go back and look at the family structure and figure out the roots of the reason why this child feels they are in the wrong body. We will stand firm with our scientifically based convictions. We invite dialogue with the other side instead of just throwing bombs over the fence, the way they do at us. We've invited them numerous times. They will not answer the invitation. And we join with broad-based group of diverse backgrounds. We have in our side lesbian activist groups who are totally and thoroughly disgusted with the concept of raising a child and affirming the wrong gender. Sounds like crazy. We're suddenly in partner with radical feminists. But they feel that there's no science behind what's being done, and they want to stop it as well. And then we never are afraid to discuss how our faith helps us in our decision-making. And as scientists, one of the things I remember from my fellowship days is arguing with a fellow from Israel who was in training, and he said to me, you know, Quentin, the more we know about science, the more we know there is no God. And I looked right back at him. I said, Zvi, funny, but the more I know about science, the more I know there is God. So we encourage the victims of drug and surgical therapy to speak out. Renee Jacks has written this book, Don't Get on the Plane. If you look carefully, it's a Trans World Airlines plane from back in the day. Very clever. It's high time that we point out that the emperor is naked. Thank you.
We wouldn't be here now if we didn't believe. We wouldn't be here now if we didn't believe in the love which is changing our lives, in the love which gives meaning to this night, or the music will die, and all that will remain is love. We wouldn't be here now if it wasn't for him. We wouldn't be here now if it wasn't for him and his love, which is changing our lives, and his love, which gives meaning to this night, or the music will die, and all that will remain is love. Our Father, He's not on cloud nine, He's closer to us than the air we breathe. He's inside of you and He's inside of me. He's standing by our side and He's in between. He loves each man with a love that's so high we can't understand, but we can give our lives. God is our Father, He's not on cloud nine, He's closer to us than the air we breathe. He's inside of you and He's inside of me. He's standing by our side and He's in between. He loves each man with a love that's so high we can't understand, but we can give our lives. Be here now if it wasn't for him. We wouldn't be here now if it wasn't for him and his love, which is changing our lives, and his love which gives meaning to this night. Are the music